So taking all of you slightly away from the usual academic discussions, I would like to talk briefly on a different topic. These days, we all are working in our subspecialties, but sometimes this makes us, this gives us a little tunnel visioning. So oftentimes we, working as a radiologist, tend to forget that we are primarily clinicians. And this is not just in Nepal, this is around the world. So time and again, these kind of discussions are happening in these kind of forums. So I take this forum as an opportunity as well as feeling the necessity that we need to remind ourselves that we are primarily clinicians, not just, radiologists. That's why I'm glad that RADCON took this theme as radiologists as clinical navigators. So hope I can do some justification to this theme. So when we talk about being a clinician, what is the essence of being a clinician? The primary we tend to feel the ownership of the patients. There is satisfaction of being directly involved in treating, managing the patients. Like many of us radiologists, I think we have worked as clinicians long ago, maybe as an intern or medical officers. We know the feeling of sitting in the OPDs, like going to the rounds, making discharges, follow-ups. So there is a sense of ownership. Working as a clinician, a radiologist also, the shift, we can see the shift at just not being adjunct in clinical decision-making, but radiologists now are a crucial component of multidisciplinary patient care. So oftentimes we are just being viewed as deliverers of a commodity. So our commodity being a radiological reports. Is that because we are unable to interact sufficiently with the patients or even with our referring physicians? And why are we not being able to interact sufficiently with them? Is it because due to the work pressure? So sometimes we keep on explaining our position of the position of a radiologist in modern healthcare environment. Because we are not just working as a radiologist, our duties and contributions are as doctors, as protectors, because the commodity being talked about, our radiological report is kind of a protection of our fraternity as well, because this is the legal evidence. So we are also the communicators, we are innovators, we even are scientists and teachers. So if we go back to the history of radiology, there was no radiologist at the beginning of the radiology faculty. It was a single field, and any competent radiologist was expected to be familiar with all of its application, even the technical part, the acquisition part, the delivery part. Later, the subspecialties emerged. And then it became too broad that one individual cannot be able to master it all. But then, have we become the victim of our own success? Because there is heavy reliance, and this reliance has given us an unsustainable work sometimes. Oftentimes, I think we all feel that this imaging has supplanted clinical judgment many a times. Because the clinicians, sometimes the radiological requests are sent way before thoroughly evaluating the patients. Radiological, like in the acute setting, even before thoroughly evaluating the patients, I mean, let's say a patient comes to an ER with acute abdomen, there is a battery of investigations sent before a clinician would thoroughly examine the patient. I'm not telling this happens all the time, but many times, like in the middle of the night, we feel that. And we have become the faceless purveyors of large number of outputs. And this makes us oftentimes tied to the workstation rather than interacting with other clinicians. So our primary role is not only to diagnose, but also involved in the treatment of patient. The role gradually shifting from remotely reporting to being a more central contributor in multidisciplinary management. But this shift, being the core of the multidisciplinary management, requires, in addition, we need to know the relevant clinical question and treatment choices to communicate with the patient. So the past model of treatment was like the image or report is delivered to the clinician, and the management decision was made with patient not being an active participant. But globally, this shift has been noticed that the management is now patient-centered care system. Like the patient is fully participated in all decision makings. Full briefing of the related radiology findings to the patient is done as well. So, like we need to have a proper counseling room if available in our radiology setup as well. How do we place ourselves while working as a radiologist? Let's say an acute ischemic stroke comes from the ER, or let's say there's a pulmonary embolism. Should we be just happy making a good report and wait for the clinicians to come and get the report, or should we rush to the emergency department, inform them proactively, interact with the clinician, and help in the immediate decision-making management, so that thus we can be involved in the patient-centered management. So we need to often go to the rounds, interact with the clinicians, toss the patients, and we need to be involved in the information gathering also. Like this is how the work flows. We see that the treatment finally depends on how the information is gathered. So oftentimes we see these kind of requests, not in particular to any institution. I'm sure we all experience these kind of requests, no clinical information. But then what do we do next? Like make our report just jotting down whatever we see in the imaging, or we actively go and see the patient, gather clinical information. So this is the active role of a radiologist, not only in information gathering, but also be part of the procedure, like acquisition. Because the quality of image, the required information finally helps in good decision making. We need to interact interdisciplinary. We need to put our heads together. We have to do multidisciplinary meetings oftentimes. And being as an IR, what we need to do is we need to have our own OPDs. We need to run our own OPDs. It's not just we rely on the clinicians' referrals, but the patients themselves should recognize IRs as clinical subspecialties. We need to run our OPDs. We need to have a proper IR suites. And above all, the role of radiology in community engagement. We also need to educate our patients, our communities. So oftentimes we are involved in these kind of awareness programs. So again, reminding everyone as our duties, not just as radiologists, but as doctors, protectors, communicators, innovators, scientists, and teachers. Thank you.